So I'm Dr Parsa. I have a practice here in Los Angeles. It's a multi-specialty practice now. It's grown about 15 providers. And it's all focused mostly on spine and neurology. I started doing OLLIF, so this talks about what my experience has been with OLLIF. And my experience started with Dr. Parsa about 2020. I saw him online, and what is this approach? I've never heard of it. Okay, this is a gimmick, and I kept following it for about 2 years, 2 to 3 years, and finally I picked up the phone and just called them and said, I'm interested, because you're still posting, and obviously these patients should be doing okay. So then I went out to Minnesota and observed a couple of the patients, and I said, okay, this might be a real deal, and I'll start doing it myself. Everything has a learning curve. My learning curve really was to put percutaneous screws. I did it in training, but in practice, the hospitals don't want to purchase navigation or anything, so I ended up doing open cases mostly. That was really, placing the cage, the OLLIF approach was the easy part. I think I had one medial breach that I had to go back in and readjust early on. Since then I haven't really looked back. Almost all of my cases, I just do the OLLIFs right now. And you know, I look at it, I mean, for you, I suspect mostly everyone here are surgeons. For us as surgeons, there are a few things that are important. Number one, surgeon interest. Surgeon interest, first and foremost, we want our patients to have the best outcome, right? That's what where we are, the practice that we do. So that's number one. Then the other aspects come second. Okay, you want to think about longevity. I was doing bigger cases, a lot of revision cases. My hands were really tired. I'm not that old, and I was hurting. And I'm thinking, how can I do this for another 10, 15, 20 years? My finger, I have arthritis everywhere. So that was one. The other, everything's going towards outpatient procedures. The reimbursements are dropping so much, especially in bigger cities in Los Angeles. It's difficult it's really bad. The reimbursements are really, really low. So you're thinking of, okay, how can we create more income? One is to go outpatient as well. And for me, another important aspect for me was the work-life balance. I'm assuming everyone knows of Dr. Parsa here and his and what the advantages of OLLIF are. One of them for me was one level. I usually did posterior fusions, so one level took me about 2 hours. This takes me 45 minutes. So that gives me an extra hour per case to spend with my children and family. So I look at it too. So the work-life balance is a big deal for me. And lastly, it's very flexible approach. Is that we know that indirect decompression now works. ALIFs, ADRs, XLIFs, right? And this is an indirect decompression. There are some scenarios where I still go open or do a decompression first. If it's osteogenic stenosis or it's a very large herniated disc or anything that there's severe stenosis, I still do direct decompression. But for the most part, OLLIF, if I want to do a fusion, OLLIF's the way I go. So let's see, we talked about surgeon interests, patients themselves, especially in Los Angeles area, or our practice spans from suburb, almost rural to suburb to city. And as you get closer to the city, everyone wants the smaller incisions. and the cosmetic approach. So this kind of helps with that. Either an ADR is nice, it's a small incision in the front, or posterior with the OLLIF approach. They want to have less pain. They want shorter anesthesia time. I've had numerous patients saying, I don't want to be under anesthesia for more than 1 hour or 2 hours. I don't know what that is for, but that's what they say. They want to return to life and work and be productive as soon as possible. They actually prefer the outpatient surgery center settings, most of the patients. And obviously they want as good an outcome as any other approach. Now, facilities is also kind of what makes the technique popular. For the facilities, especially the hospital, it's low cost, low cost, low cost. It's what's been my experience with the hospitals. They do not want to get navigation. They don't want to pay for X, Y, Z. It's very, very difficult. Also, one of the reasons I just did open cases. I do everything freehand. It was easy. They were very happy, very cost effective for the hospitals. They want lower revision rates. They don't want to see the patient's back. I guess the insurance doesn't pay them if the patient comes back, supposedly. They would want to keep the best quality. So they basically want everything best quality for lowest cost, the bottom line. Now, what's hot in spine surgery, if you look at it from another perspective, is endoscopic spine surgery. You hear about that a lot. We do them. I think it's again, you don't need any extra instruments. The technique's very similar. I personally did probably about 40, 50, and I've reverted back to regular micro, just because I don't see any difference in patient outcomes, and my patient population doesn't care about, literally a difference of a half centimeter. My partner still does it all the time. But that's what's hot, and I see why. But I think in the future, if it comes to fusion, OLLIF's the way to go. It meets basically all the criteria that we talked about for surgeon's interest, patient interest, facility interest, and it mimics the advantages of endoscopic spine surgery for decompression events. Again, everyone knows how OLLIF get to the spine. This is what I'm always afraid of, the exiting nerve roots. I'll talk to you about my experience in regards to that, and then I can show you some cases. So, ultimately my experience with the procedure has been, my patients' long-term outcomes are almost identical, if not slightly better with the OLLIF compared to open PLIFs or MIS TLIFs. I do some ALIFs and ADRs, but it's basically, if I do 15 of the other, I do one of ADR. So I don't want to talk too much about I don't have that much experience. You guys have a better experience with that. So the big things are the patients do remarkably well for me right after surgery, after the OLLIF approach. They're out the same day or the next day. My PLIFs and TLIFs and all the other ones were at least in the hospital for 1 to 2 nights. The biggest thing was they were in a lot of back pain. The OLLIFs don't have that back pain. In my patient population, almost 75, 80% of my patients do develop some sort of radiculopathy or radiculitis in their left. I go from the left side of the book, they do too. It's easy to manage it. A lot of times it actually happens 3-4 days after the procedure. I give them a steroid pack, it's gone within a day or two, it's much less, and within a week, 2 weeks after that, it's gone. The longest I've had it is some numbness tingling 3-4 months out, which that also can work. So that was my biggest concern of the approach before I started, and what I'm doing, and I still see that it occurs, but it's not fearful because I know they get better. And for me, none of them have had a drop or a weakness. It's always pain. The worst has been this just severe burning pain in the distribution of, and it's usually L5S1. The L4, 5, L3, 4, experience. The L5 is when I think the angle you take, you start irritating the exiting nerve. I've done the transfacet approach. Whenever I go in, I see that the exiting nerve was stimulating too much, like 3.54 milliamps, then I use the transfacet approach. And that's helped, but they still develop the reticulitis in my hands. That's really my biggest, I guess, not concern, but biggest thing to sort of expect at this point, that they'll develop that. Otherwise, they do wonderful. Patients are discharged. These are my earlier, or 6 to 8 months ago. I'll show you the case I actually did this week. So here's a deformity. I think earlier on we had to talk about deformity. It's not sagittal deformity, it was more sort of mild coronal. You know, how old was she? She was a 72-year-old female, very large, BMI 45, diabetic, osteopenia, a lot of back pain, bilateral radiculopathy. These cases I'm very conservative, do as much pain management, especially when you're older. She wasn't getting better, so I did an L2 to 4 OLLIF. She did quite well afterwards, and these cases, they do not get the radiculitis when they're higher up either. But it's again in my hands. This is the case I did this week. 60-year-old male. So we did conservative care for more than 2 years. It was about 2021 or 22 that I saw him, and I don't generally like to operate on just disc disease and mild to moderate lateral stenosis. But his pain was initially controlled with our pain management team, MBBs, RFAs, epidurals. He was doing pretty good until he wasn't anymore. So the worst 2 levels are L4 to S1. Then we scheduled him for surgery for the OLLIF. And he didn't pass his clearance. They found that he's got a large clot in his heart, and they had to go do a stent and everything else. So then his cardiologist said, you cannot be under anesthesia for long or on your chest. So he was very concerned. Again, that's one other advantage of OLLIF, is you're not under anesthesia or prone for a prolonged period of time. So we did it this Monday. This is the procedure, the lateral. It's about an hour and 20 minutes or so. And what's interesting, so he's a chronic pain patient at this point, right? So I didn't think he's gonna get up and leave. He requested to be discharged 8 a.m. the next morning. Since he was running around. No radiculopathy or radiculitis. I expected to develop maybe in a few days. He'll probably call us and say, hey, I'm starting to feel. That's what I've been used to. So I already have the steroid pack on hold to give to him. But again, these cases, this would usually take longer than an hour, 20 minutes. Almost no blood loss. Sorry, we did a 3-level. This L2, 3 had some issues, so we did L3 to S1. And total fluoro time was, I have it here, 4 minutes, I think, around 4 minutes, which is not bad. What I do during these cases, I think Dr. Parsa does, I do an epidural steroid at the very end, and then I also do TP box on the level above. So that really helps. Let's see. Here's our AP views. I never get over this. When you're doing it and you get the disc spaces all collapsed and it just pops right up. And then the neuromonitoring tells us five minutes later or so, oh yeah, the L4 nerves are doing better, L5 nerves doing better. So right now, this is probably one of my favorite approaches. As I said, patients have done well. My experience has been good. I think you guys have experience too, so I'm open to any especially with the radiculitis. I really want to know what everyone's doing and what your experience has been.
Todd, what's your experience with post-operative radiculitis for these kids? You
Well, I
take
do
a slightly,
these.
you do a different.
Well, I did the anterior, but yeah, I'd never seen. I didn't even know what it was until I just saw your videos. I mean, they're getting sympathetic when they enter. They're not getting radiculitis.
Oh, you do the
I do
OLLIF
the-
from oblique.
Yeah.
Instead
Rather
of
than
XLIF, you go.
lateral.
Yeah. Yeah, my partner does that too. A lot.
I did
When
some-
he switched to OLLIF, I does OLLIF.
Yeah,
Like this OLLIF, not that OLLIF.
that's confusing.
It is good, yeah.
I would say it's radiculopathy is straight lateral, sympathetic